Good evening, everyone. I'm Dr. Usha. Greetings from Jaideva Institute of Cardiology. I thank the organizers for giving me an opportunity to share this interesting experience. Sailing the Uncharted Waters, Interventions in Aortoarteritis. This was a 19-year-old female who came with a history of headache and fatigue of 3 months duration. She had a past history of aortoarteritis for which she was treated at our institute. At presentation, she had a right upper limb BP of 190 by 110 millimeters of mercury. The lower limb BP was 130 systolic with a gradient of around 60 millimeters. Left upper limb pulses were not felt, were very feeble. Cardiovascular system showed loud S2 with no significant murmurs. Echo showed concentric LVH. LV ejection fraction was 40%, and there was dilated and narrowed thoracic and abdominal aorta with a gradient of 35 millimeters of mercury. Past history, she first came to us at 14 years of life when she came with acute decompensated heart failure and was found to be hypertensive. She had severe narrowing of upper thoracic aorta for which we did balloon dilatation with good results. She was started on immunosuppressants. She came for 1 year and she was then lost to follow. 3 years back, again she came at 16 years of age with hypertension and class 3 symptoms. At that point of time, the aortic flow was good, but we found that she had developed right renal artery stenosis. And again, balloon angioplasty was done and the flow was restored. She was again lost to follow-up for last 1 year due to COVID. 3 months ago, she came with history of headache and fatigability and her BPs were high. ESR was 30 and CRP was 3 milligrams per DL. We started her on MMF, which is the protocol at our hospital. Imaging at this point of time showed a recurrence of stenosis of the right renal artery. There was 90% critical stenosis. There was irregular thoracic aorta with points of dilatation and narrowing. And there was a pre-existing narrowing of the subclavian artery. Investigations showed HB of 11 grams with normal counts. Acute phase reactants were normal. Renal functions were good. So we planned a renal and aortic angioplasty. We took a right femoral artery access with a 7F sheath. Pressures recorded showed an aortic arch pressure of 140 by 66. Thoracic and abdominal aorta showed around 90 by 56 with a gradient of 50 millimeters of mercury across the aorta. This is the renal angiogram. You can see here there is a critical narrowing of the right renal artery. The left renal artery is good. The angiogram of the aorta showed areas of aneurysm followed by stenosis and irregular aorta. This is the abdominal aorta, which also shows narrowing, again followed by aneurysmal dilatation. So there was a long segment narrowing and aneurysm before and after the narrowing. So we first decided to go ahead with the renal dilatation. We used 3.5 into 15 and 4.5 into 12 coronary balloons. And you can see post dilatation, the renal flow was restored. The renal artery lumen looked good. So we went ahead with the aortic dilatation. Initially, we thought of using the Atlas balloon, but we were worried about the increased risk of dissection. Hence, we took a tie-shack balloon of size 12 into 30 mm. Since it was a long segment narrowing, there was a little bit of melon seeding happening. But with few dilatations, we were able to achieve good result with disappearance of waste. So after balloon dilatation, we introduced a guide catheter over the wire and we recorded a pullback gradient. Now, after dilatation, arch pressure was 144 by 60, whereas abdominal pressure was 130 by 60, and only 14 gradient was measured, and pulses was well felt in both the lower limbs. So we decided to do an angiogram. We exchanged the PTCA wire to a Teflon wire. We introduced a pigtail over the Teflon wire. There was some resistance encountered for the passage of catheter. And we did the angiogram. So what was seen in the angiogram was quite shocking. There was a large dissection which was starting from the thoracic aorta. It was spiral and it had stopped in the upper abdominal aorta. There was a large false lumen which was created. And with time, this false lumen started enlarging and the true lumen had become narrow. So there was a worsening collapse of the true lumen. So this patient would end up in intestinal ischemia. All the celiac and the mesenteric arteries were below the dissection. There would be renal ischemia and lower limb ischemia would all lead to disastrous consequences. So at this point of time, we were worried about one thing. While exchanging the wire, there was a partial withdrawal and we had to reintroduce the wire. So we were worried whether we created the introduction of the wire, created the dissection, whether the wire was in the true lumen or the false lumen. To confirm, we took a right upper limb axis with a Termo 035 and snared it out from the femoral end. And we did an angiogram from the upper end that showed that the false lumen was separate. It had enlarged considerably, and the wire was in the true lumen. And there was a long dissection. We had to stent this dissection. How much to cover? The entry site always has to be covered ideally, and we had to expand the collapsed true lumen also. So we had only 114 into 120 millimeter barred self-expanding stent. It would not cover the entire length. So we decided to cover the collapsed portion of the true lumen. Otherwise, the flow to the lower part of the body would not be restored. So we positioned the stent across the dissected aorta, made sure with a small injection that we were in the true lumen, and we deployed the self-expanding stent. Once it was deployed, there were no pressure gradients recorded. The pressures were equal in the abdominal and the thoracic aorta, and you can see the flow is smooth, and the lower thoracic aorta, lower abdominal aorta is well perfused, and the pulses were well felt on the other side, and the femoral sheath showed pressure recordings which had become a flat line earlier. Take home lesson: Taishak is a semi-compliant balloon in an adult aorta. It can still cause a dissection. On immunosuppressants, she had no lab evidence of activity. That does not guarantee against dissection. Would primary stenting have prevented the catastrophic event? We have done primary stenting earlier. We have again landed with complications with acute stent thrombosis within 10 days of stenting, and we lost that child. So either way, we are in a difficult situation. We don't know what is in store for us. But it's very important to have adequate stents on the shelf. Disease extent and activity is underestimated by routine inflammatory markers and echo. And Takayasu arthritis is a disease of unknown etiology with unpredictable course and ambiguous treatment strategies. Thank you.